My name's Justin Davies. I'm here at EuroPCR 2018, and I'm joined by co-founders of CoFI, or two of the three co-founders, Martin Rothman and Rob Schwartz.
Hi.
Hi, guys. We're here today to talk a little bit about some interesting developments that you've been bringing to the market and some new concepts and new ideas in and around the microcirculation, problems we've got with measuring it, why it's important, and the need for a new technology in this space. So, Martin, maybe you just want to start off by highlighting the problems here.
Well, all of us as interventionists have had experience where we open the epicardial vessel in an acute MI situation. And in some of those patients, we can see very obviously slow flow in the distal vessel. So you've got some form of obstruction, presumably. But in some patients, you also have a situation where the EKG doesn't go back to normal, yet the flow looks sort of okay. And it always puzzles me that that something's going on downstream. You then look at that patient over a period of time, look at their CMR, and you find that they have a substantial infarct. Then even worse, later, they have a heart failure event, and we've contributed to that ongoing event. So we're not doing everything we could by doing a primary angioplasty. And the problem, of course, is you can't diagnose that downstream event unless it's obvious on slow flow or it's obvious on continued ECG abnormality. And we've come together to try and be able to diagnose that in the cath lab during the ordinary workflow of a primary angioplasty, and also to treat it.
Okay.
So that's the challenge.
It's good. I mean, you've got a clear objective there, what you want to do. Often these areas of physiology baffle people because they're very complex and understand by a few people around the world using tools which are somewhat not optimized always for difficult clinical environments. So Rob, you've been working to evolve the space, looking at new tools, new ideas, new concepts. Could you just outline a little bit about what you've been doing?
Sure, happy to do so, Justin. In the cardiology world, we usually think of pressure. Pressure is everything because we can measure pressure.
Yeah.
We can't measure flow very easily. So we flipped that on its head and said, look, let us then set the flow and then measure the pressure backwards. So we set the flow with a computer pump. It's driven very precisely, and in the process block the upstream vessel with the balloon. We therefore know exactly what the flow is. We know exactly what the pressure is. We therefore have a very precise definition of distal microvascular resistance as the quotient of pressure over flow.
Fantastic. So it's a way of making things or removing some of the variables that we have in day-to-day practice. So if you want to effectively assess microvascular resistance, we have a huge range of pressures, a huge range of flows which could influence things, drugs which affect this, systemic blood pressures which could affect this, epicardial disease which could affect it, and you're just trying to remove some of these variables to essentially give us a more pure measure.
Very much so. Now what's very interesting in some of the early animal data which have now come out are very clear that the microvascular resistance changes with the perfusion pressure, so that as you change the flow, you change the pressure. Turns out the microvessels start to collapse actually very abruptly and very explosively at a mean pressure of about 30 to 40 millimeters of mercury. Below that, the resistance goes sky high. Resistance just goes through the roof, and if in fact we let it go all the way down, the vessels would probably close completely. That's important because there is then no such thing as the microvascular resistance. It is in fact a curve that is low resistance as the pressure is high, but as that pressure drops in the coronary artery, it goes very, very high.
So I think what you have shown very nicely is using in modern techniques is very similar to the really fantastic work done by Jos Span, the MC in the 80s, where he was obviously using more invasive techniques, clamping arteries, inserting big pumps there, but essentially showing that you start to get reversal of flow at 50 millimeters of mercury, and then you get this paradoxical constriction when you go below that. And that's, of course, what we see sometimes even with adenosine in the cath lab.
Absolutely. And how many times have we been in the cath lab, a patient coming into cardiogenic shock or getting low mean pressures in the 30s, 40s, 50s? That is the point, at least in the animals, that show now this is a very dangerous time because at that point these capillaries are beginning to close.
And we all know this as interventionists, that when someone's blood pressure gets to 50, everything's there's danger usually around the corner. So Martin, I'll ask you, when are you going to use this? Clearly at the moment it's still in the development phase.
It's still very much in the development phase. But part of the drive here is that we've all been in a situation where we've seen this problem, and every method of treatment, let alone diagnosis, has failed. And our supposition is that it's because you're not actually getting the drug, if it is a drug, or flow to the distal bed. So in our model, we actually occlude the vessel with the problem, and then we can infuse a therapy to that. So we think we're going to have a difference in outcome. And whilst the episodes of clear clinical no reflow only happen in 8% of patients or whatever, and more commonly at very low blood pressures and cardiogenic shock, MRI suggests there's anything between 40 and 60% of continued damage when you measure it at 3 to 5 days or even later. So the first issue is, in whom are we going to treat? And the issue there is very clearly, if we are right and you can measure high resistance in these patients, then those are the people to treat. So that's the supposition.
So primary PCI patients?
Primary PCI patients very clearly, because there's a very high incidence of muscle death, but also NSTEMIs, for example. And of course that won't be a popular suggestion at this stage. We need to prove that that's the case. But there is clearly a stuttering event going on in NSTEMI. And the question that may be, is it okay to put this patient on the floor overnight and just give them nitrates, or should you be really doing it right now?
Justin, it's very interesting to come out now. If you take a look at the MRI literature, a lot of this theory has come out. Microvascular obstruction, yes, begins at the time of the index event, but it may continue to grow throughout 9 days post-event. And so there is indeed a therapeutic window there, given that this evolves over time for the worse, that if you can make that intervention, even at perhaps 1 day, there could be a substantial change in patient outcome long term.
So you index procedure or a day or so afterwards?
No. Index procedure. The intent of this is index procedure, either where there's a suggestion of a problem, or maybe in due time a routine measurement of the distal pressure and flow and resistance, and then to go on immediately to do therapeutic intervention. That makes it a one treatment procedure. And the issue with being able to measure the resistance in the distal bed is that you can actually say, when is the procedure over? Have I done enough, or have I gone directionally enough? And we couldn't tell you whether it goes back to normal yet, the resistance, but the intent is to treat at the time, because otherwise the patient has to have 2 procedures. Otherwise the patient will have maybe established muscle damage by the time you come back.
Okay. So the Achilles heel of this whole field is the fact that we can make measurements outside of, and the reason why physiology is huge in coronary artery disease. You've got a stent which treats epicardial disease, But the Achilles heel of all microvascular disease assessment, all resistance assessment, is the fact that there's no treatment. So what are you going to do in this space? Are you doing stuff here as well?
Well, part of I'll let Rob answer that, because we've got some interesting information. But part of the assumption of all of us cardiologists is that you've got thrombus in the acute lesion in the main epicardial vessel, and you've therefore got thrombus in the distal bed. It's obvious, isn't it? Well, we've, in the pig model, have found it's not so. We see very little thrombus. We do see some platelet aggregation, but we don't see the massive thrombus that maybe we had expected. So first thought before we got that information was, well, it's easy. We'll treat with an antithrombotic drug. Maybe that's right, maybe it isn't. I don't know. But at the moment, we plan to propose abscesimab as the first drug to investigate.
Oh, absolutely. When you think about it, if you have a set of the microvasculature that's obstructed, another subset of the microvasculature that's open, you give a bolus drug, such as was done in the Infuse AMI trials, where is the drug going to go? It's all going to go down the open vessels, and where you want it, in the closed vessels or the semi-closed vessels, it's not going to go. So part of the technology is to develop a strategy to, in fact, equalize at least, and perhaps even favor the vessels that are obstructed. And we do that by manipulating the resistance curves I just talked about as we drop the pressure. If we infuse at a low pressure, low flow, in fact, then the large vessels that are open increase their resistance to that roughly the same as the obstructed vessels, and we thus can favorably affect the flow distribution between the obstructed and the non-obstructed vessels.
Right. Well, I think this has been a very interesting insight into a technology which is evolving from the animal lab and moving towards to patients and clinical stage of its development. I'd like to thank Martin and Rob for joining us here at PCR 2018. It's been my pleasure to bring you this short segment on this new technology. Thank you very much.
Thank you.